because this is another typical problem. When we finish the case, we don't have overjet, we have contact edge to edge anterior, and in posterior we have open light. So what happened with these cases? This is typical with Invisalign. We use a lot of elastics with buttons and elastics. But this is, the problem is not the posterior area. The problem is the contact of the anterior area. So if I have the result, this contact, normally the occlusion is coming on the rear. Okay, so this is the diagram. Nothing more. Okay. And the technician sent me this. How do you see different between the others? Right. The first that I don't believe it happens is the technician. If I don't ask nothing, they put me a cut button in the buccal surface on the first molar, in the palatal surface in the upper molar. But they correct the crossbite on the 6, and when finished, start to using the crossbite for elastics in 7. So, do you think, or do you have any other brand that doing this sequence? I never. I use Invisalign. In Invisalign, if you don't ask a cat, they don't put never. Never is never. In Spark is not only they don't put a cat, they don't put an attachment. In the molars, never. You put a gun in the head of the technician, don't put attachment. So this is the first case and the first design. So when I use the first, I say, okay, the smart is different from the others. Because they sequence the expansion, the first molar, the second molar. So this is more predictable. And in this case, you can see it's an express. It's not infinity. We can resolve this case in 35 alignments. 35 alignments is the express for the last year. Right now, with this case, with this package, we have 40 alignments. We have 5 aligners more. It's like light package. Light package, we have 20 aligners until the last year. Right now, we have 25 aligners. So we can resolve a complex case with class 2, short class 2 malocclusion, with crossbite, with here, you can see we are correcting the class 2 malocclusion. But this malocclusion, I don't ask nothing about to correct the class 2. I don't ask using precision cuts or maybe elastics, nothing. But the technician put me because I need. So this is very different from the others. What happens? Maybe the technician is a very good technician, of course. But what's different between Smarty? Because this treatment plan have a filter for orthodontics before coming to. So this is very important. So this is like the first case, I feel the Smarty is different. So with this, I start using more cases, and I feel that the technician and the orthodontist who review, she knows orthodontics. It's not that the other brands. If you don't ask, for example, nothing, maybe in Invisalign, maybe they don't move the teeth. Or if they move, they don't put, for example, the cuts. On in the other side, never. If you don't ask these cuts, they never put these cuts for the elastics. So, in fact, now with the new Smarty check, not only you have these cuts, so the new one, you have like a new window saying, doctor, we recommend you use the elastic 316 with 3.5 bones for force. That they told you all. So this is very, very easy for us, even for the treatments. So this is different, totally different from the others. So this is the most important. Well, For example, in drilling, in my cases, so in growing cases, I can filter here. So in 300, I have 106 cases for. Okay. So the first I use is Tinder. You can see a lot of cases. Normally, I think that 80% of cases maybe is T, and the other is Tinder. So you can see I have maybe 1/3 of my cases are in growing patients. Okay. And let's go to see the life update. Okay. For example, this case. Okay. You have here, in this case, the patient goes there to number 25. I want to maintain this space for an implant. So you can see here, I use the crosswise elastics to correct the posterior crosswise. Okay. The first that I need to do is correcting the crosswise, and when I have this space, I recognize these sizes. Well, so maybe I want to use the life update. The life update normally use between 20 seconds until 150 seconds, maybe for the complex of the movement. And they have like limitations. What is the limitation? The limitations is, for example, if you want to move the teeth 1 millimeter, you can use life update. More than 1 millimeter, you need to sum it. It's important. If you want to change a rotation more than 10, until 10 degrees, you can life update. More than 10 degrees, you need to sum it. So, and in the case you have like S11 solution or maybe mandibular advancement, normally you need to sum it, right? So, but the 80% of the cases, normally, when you ask, this is the first treatment plan, and I have another different treatment because in other tours, in other lectures, I use this one like example. So this is the first one. So with these limitations, normally, if you ask to the technician and you write all things like this one, you can see normally I always write to the technician a love letter because I write a lot. Please, extraction from the beginning, 18 and 28. Expand both arms around 2 millimeters. Expand and then rotation the superior molars at the same time, doing mesial out on the first molars, so distal in on the second molar. This is more predictable. This is more predictable protocol for the expansion. Correct the crossbite posterior, next expansion, 18-20%. Finish with at least 1 millimeter and leave at least 7 millimeters and leave for the 25 for the posterior rehabilitation. So this is all my letter, okay? And the technician do all that I want. Maybe I don't want this IPR. Okay, perfect. I go here and I remove this IPR, for example. So I have my midline center, or for example, I want in this case, maybe the gingiva is in the same position, but I don't want the gingiva. I want maybe the edge of the teeth, because here we put a bullish or wherever. Perfect. Okay, I want to remove this IPR. But for example, okay, no, I want to do an IPR in the lower arm, or maybe to change this to this rotation. So, change this, okay, and maybe I want to do IPR here. You can see, okay, but this IPR in which phase I want to do. Because maybe at the beginning, like this, or maybe in my protocols, normally I don't like to use the same day, put the attachment and do the APR. The same day, normally for the patient is a lot of things. So normally it's the first day. I use the attachment, I put the attachment. So step 0, but the APR I want to do, for example, on maybe step 3. So I come here, step 3. Well, step 3 is start in step 4. Okay, 0.5. I change here, 3. So I can individualize every that I want. And for example, I do the comparison. In this case, the crossbite. The crossbite, you can see the precision cuts, the cuts, they were moved in aligner 24. You see? But it's for example, this crossbite is not corrected in this at this moment. What happened? I need to do manual discard. So in this case, okay. So I am afraid I'm going to use this one until the 5. So I change 14, 40. And in the upper, the same. 14, 40. Well, the software has an autosave every 5 minutes. So I always recommend to save every change, to press this button to save. But normally, every 5 minutes is autosave. So, and in this tip, for example, if for example I want to make this like this, do you know this feature, auto attachment? If I press here, if the movements don't need more attachment, they don't appear. But if I want to do something like this, very long, but here it doesn't work because I do a lot of movements. So, this is my training plan. Okay, life update. Yes. So normally, when you say it's like around 150 seconds, normally it's less than 1 minute. So it's approximately. So with this, I have the new animation. In this animation, we have 2 options. Maybe to approve this new animation, maybe cancel and come back to start again the modification, or maybe approve and start a new animation. It's 2 or 3 options. For example, okay. I have my new animation. You can see here, this for example, you can see this right here. I change to aligner 4. The attachment, if I compare with the first one, the buttons here in the first disappear in number 24. I change to have the buttons in the final. So this smart check gives me the option to individualize every movement. The attachment, when I want to use, when I want to remove, the buttons, all that you want. The idea in which phase you want to use. So it's very, very, very special because it's a technical decision. Maybe if you want only to give the option to the technician to give the work for you, okay, it's okay. But you have the option to individualize everything. And you can see, in less than 1 minute, you have the final. And for example, if you like this one, okay, if you like this one option, you approve, and you have your smart check ready. Well, questions about this?
Do you have a problem where you edit the animation for maybe a little bit long, 5 or 10 minutes, and the system freeze? And when you reopen, that is all the thing that you changed gone. Have you experienced that?
No. Never.
I used to send days and like we said.
Yeah, it happened to me maybe 3 or 4 times.
I never had this problem.
I have to take a photo and give them like the video.
Yeah. But for me, it's the first thing that I heard this. For me, never. But maybe the software, maybe the software is like this. You know, Smarty is always every week, every 2 weeks, is making a new update, new update. So maybe in one update of this, you have this problem. But normally, I never have this problem. And I use a lot. The life update for me is one of the best tools that we have. So, for example, I work with the technicians, with the medical team, with the support team from Smart Team to have the best software.
You are lucky.
Yeah.
So, to say this, maybe Apple MacBook is what kind of computer you're using? MacBook or Windows?
No, Mac.
Mac.
Yes, Mac. Normally, you know, the software the Smart Team is working by web. So, what feature do you use? Chrome, Google Chrome, or Safari? No, Safari for Windows. No. Do you use Windows normally? And what is your? It's Chrome. Chrome. Normally I use Chrome. Normally with Chrome and Mac, I never have a problem. It's true, I don't know for Windows. I don't know because I changed like 20 years ago to Mac. I don't want to come back to Windows. So with Mac, I had never had a problem. But it's true, like it's by web. Sometimes if you are using Firefox or maybe Chrome or maybe Edge or maybe Opera or maybe different. But normally with Mac and Chrome, I don't have any problem. So maybe it's for the computer too. I don't know. Or maybe it's
And
programmed.
I saw that you give instruction in Spanish. You give instruction to the team in Spanish.
Yeah.
That's nice.
Yeah. No, in fact, for example, another good thing that you have in Smarty, for example, is that you can write here your training plan. You can write Vietnamese. It's no problem. So Smarty have a here to translate to Chinese. So, for example, when Angel comes to Spain, they always say, no, doctor, it's mandatory to write in English. So a lot of colleagues, they were crazy to translate all the Spanish words to English. And sometimes the kind of you can make the expression is different in Spanish to English. It's like you. Maybe in Vietnamese is different than what you talk in Vietnamese or in English. So you can write in your language. Don't worry. The technician, they have a special AI software to translate to Chinese. So it doesn't matter, you can do right. So, like this software, the Smart Teaching software, is a very powerful software. I know all of you are using Invisalign. Invisalign have a very good software, this is true. The clean check is very powerful. In fact, it's the software, it's the oldest software. So the Smarty software right now, for me, is like similar just from the Invisalign. But I know in the next month, it's better from Invisalign. I'm totally right. Why? Because, for example, we have the life update. Invisalign has the life update too. So, with life update, we can use, you can see, we can individualize the idea. We can individualize when to use, to put or remove the attachment. If you want to, for example, use for example, if I want to use, I want to modify, if I want to use, for example, the Smarty button or Smarty hood, I can use this one. Use the life update. And in the next month, we have passive aligners. Which is passive aligners? Passive aligners is for me, in all my treatments, at least in the first package of aligners, I always ask for final passive aligners. Why? Because I always, normally in my cases, I always ask refiners. Normally, I'm a refiner. Do you know how many cases in my life I treat more than 2,500 cases with the aligner? In how many cases I finish only in the first package of aligners? Maybe 3, and only 1 with Invisalign. The other is with the Smarty, actually the case. It's amazing. So normally I ask for a refinement. So this refinement, I don't like to the patient is wearing the same aligner. It's true, and you can see if you see the aligner from the Smarty, is very clear. It's different from Invisalign. So when the patients come to my office, sometimes the patient say, "Doctor, I want to treat you with Invisalign." And the patient say Invisalign because they heard Invisalign. It's like the brand, no? It's like maybe like in Spain we have like the soft tissue. It's like Kleenex, no? It's like the brand. Can you give me one Kleenex? No, it's Kleenex. It's one soft tissue that is not normal. It's normal. So when you come to my office, the doctor, I want Invisalign. No, you don't want Invisalign. You want clear aligner. Because we carry Invisalign sometimes. And the doctor, no, pero I heard my friend, or you treated 2 years ago, my friend with Invisalign. What now you are telling me about different brand? You see, because this brand is better than Invisalign, and the aligner is very clear. And I take one aligner from Invisalign, one aligner from the Smarty, and give to the patient. And say to the patient, okay, what do you feel is more clear? Oh, this one. This is what is Smarty. With this, the patient is okay. Because it's very clear. In fact, this last week, they come a patient to my office with aligners. Okay, when do you need to change the liner? Today. Today? But this is new. No, I use this for 10 days. This for 10 days? Really? Do you use? Yes, I use. It's very clear. It's like new. So, and the new one is perfect. So, this is one of the best things they have in the Smarty. And when the patient comes to always Invisalign, because it's normal in the patients, always carry Invisalign. Or for example, I have a lot of patients treated with Invisalign, and now it's coming the sons, the brother, the friend, wherever. When I explain the treatment plan, I don't talk about brands. I talk about clear aligners. This is treatment with clear aligners. Okay, the patient asks you, and what's the brand? The brand is Smarty. Oh, it's Smarty. Why not Invisalign? Because the Smarty is the same. It's a clear aligner with a very good software, with a very good aligner. It's like the patient, it's more clear, whatever. So at the final, what's the important thing? The important thing are the doctors. The patient doesn't come to your office for a brand. It's coming for you. So it doesn't matter the brand that you use. The patient trusts you. So you need to give the best for the patient. And sometimes the best for the patient is that you think is good. Some doctors they say, no, I am with Invisalign, I don't want to change. Perfect, I understand. Perfect. Okay, the most important is the doctor feel comfortable with the brands. But I don't understand when the doctors say, no, I use Invisalign because it's the best brand. Or Invisalign or wherever. Invisalign with Smarty, with wherever. Okay. You trust anything, any other brand? No. So, how do you know is the best? Try it, another. So, I always say the same. Try it. You are using Smarty. So, the doctor that you are not to use Smarty, try the Smarty. Do you feel comfortable with Smarty? Use Smarty. Do you think you don't feel comfortable with Smarty? Don't worry, use the brand that you want. This is a free market, so you can use. But for me, what I change all my cases for Smarty because I have a very good software, a very good material, a very good technicians. So I change all my cases to Smarty, and I'm very happy to do this decision. So it's my decision. So each one has your decision with your life and your patient. So for me, for giving the patients the different solutions, the different options, and this software they tell you. In the next month, we have the passive aligners to ask that maybe in the same case to life update and to use passive aligners. With this what I have in my mind. In my mind is if it's possible, the doctors, the problem for me, the doctors, will we change for traditional braces to invisible aligners was a problem. But we spent a lot of time in front of the computer. True? We spent a lot of time now from the computer. So we need a good team behind, a good technician, we need easy our work, a very good software, because I need to spend less time. So we are working in a smart team, we are working for in 10-15 minutes, you have your final Smarty check to approve. No more time. 10-15 minutes. This is the ideal time to approve the case. Not like 2 or 3 years ago, like you have the first design, you need to send to the technician 2 days before coming back. Oh no, I forget this attachment, or I forget this button, coming back, and maybe 1 week, 10 days to approve one case. This is crazy.
So who makes the passive aligner for you? Who will have recommend to have a passive aligner?
I recommend passive aligners normally at the end, 4 passive aligners.
But we have to comment, right?
Yeah.
It's not automatically, we have to comment that we want passive aligner.
Right now, you need to ask, yes, but in the few months, you can do directly use. So here maybe appears a button to passive aligners, you have passive aligners, and with the life update automatic, you use at the final of the tool. This is the idea. So in 15 minutes, you have the case to approve directly. This is the idea. So this is the only software that we have for all of these things. Good? We need to show another case. Yes. Yes.
Dr. Vicente, I have a question.
Yes.
You mentioned about the passive aligners 4, right? So for each set, do you recommend 10 days, 14 days, 7 days wearing until you get the new sets?
The same of the active aligners.
Similar.
Similar, yes. So, for example, I recommend in my protocols, I always ask 4 passive aligners. Maybe other doctors 3 passive aligners.
But I mean from the beginning of treatment, you change from the raised orthodontics to the clear aligner. So you order them the passive aligner. But how about when you change from phase 1 to phase 2?
No,
You ask
the passive aligners,
yes,
the final.
the final.
Final passive aligners, yes. It's because when you finish the first stage of the aligners, normally you need to make a refinement. This refinement is to make the scanner, the photos, the radiography. Okay, you send to a smart team. Normally, what time it arrives? 3 weeks, 4 weeks, maybe. So in these 3 or 4 weeks, the patient, if you're using the same aligner, maybe within a smart team, it's very clear in 3 or 4 weeks. But normally, 10 days, maybe it's the patient wants to change, not to a new one, maybe from the flavor, maybe wherever. So this passive aligners is final until they arrive a new one. It's for this reason. It's not for no reason, it's in my protocol. Some doctors, they don't use passive aligners if the patient is with the last aligner 3 or 4 weeks. Okay, perfect. But for my patient, for at least in Spain, the patient is very special. No? They want always to have a new one. They don't want, oh, this is 7 days, 10 days. No, it's very bad, whatever. Okay, I always ask. It's true that, for example, this case is an infinity, but imagine that this case is an express. I have 14, okay, 14 aligners. So in this case, if I have 40 aligners, if I want this case for express, I don't have more aligners. So I need to approve this case if I want express package. So this is an infinity package. I want to ask. And normally, maybe the passive aligners, normally all the brands, they give you the option to ask maybe 4, 5, or maximum 6. Like a Spark, you can to ask 6 passive aligners, no more. Because what happened? In Spain, the people is very smart, and they say, okay, I think it's the case, so I ask 20 passive aligners. And they use these passive aligners like a retainer. Yeah, we know. Yeah. So normally it's 4, 5, or maximum 6. In Invisalign normally it's 5. In Spark it's 6. In Angel is 5, maybe around 4 or 5. This is normal.
In Symmetry, do they have overcorrection with the virtual CT aligner?
With the overcorrection aligner?
Yes, with virtual CT.
What is this?
Virtual CT.
Ah, with C-chain. Yes, you can to ask.
Oh,
Yeah, so for the doctor is asking if it's possible, if in Smarty, asking the C-chain. So the final, for example, you have a case, you have a lot of APR, so in the software you close, but sometimes there is a little space, and you can to ask at the end the C-chain. Is this one? So, of course, you can to ask by the technician final C-chain, maybe in the lower, maybe in the upper. But you need to ask. In the other brands, it's the same. You need to ask, always, in the other.
you said that we can decide how many steps we want a person, right?
Yes.
How about if we want to do a movement, for example, we want to intuitive in 10 steps only. When you do that with the license or with the technician?
Normally with the technician, because for example, if you want intrusion, you need to know the algorithm. The algorithm is the normal movement is 0.25 millimeters. So for 4 aligners, the intrusion, maximum intrusion is 1 millimeter. If you are to the technician and you want to intrude 2 millimeters in 4 aligners, it's not possible. You need at least 8 aligners. So this kind of movement maybe is very hard. So sometimes, if you have, for example, you have 40 aligners and you need to intrude 2 millimeters, it's better so sequence this intrusion, not 0.25, maybe 0.1 millimeter, because it's more predictable. So normally this is writing to the technician. The life update is the option to make change, some change that is not like hard changes, because hard changes or the sterilization, for example, if you want to have a class 2 malocclusion and you want to, for example, you ask only a line and you say, oh no, I want to change my treatment plan, I want to make the sterilization. It's more than 1 millimeter, you need to write. So, and normally I always say the same. The big changes, always write, always. The small changes, do by yourself. But if you have, for example, a correct class 2 or correct class 3, don't start to move one teeth, another teeth, no. It's preferred you write. Dear colleagues, please correct the class 2 malocclusion with dispensation of the automotive into class 1. Please use elastics or right. Yeah, it's better comment. The big changes, always comment right to the technician, always. The small changes, do by yourself.
So if like that, the life update is for within 1 millimeter, or the rotation is about 10 degrees.
Yes.
So it's like roughly 4 set alignment. Right?
Yeah.
So it's a very minor thing.
Yes.
when you do it yourself.
Yes. The limitation is 1 millimeter and 10 degrees. And of course, if you are using mandibular advancement, ACE8, or maybe ACE11, this is not applied. You need to submit. But normally, with these limitations, you can maybe to the 80 or 90% of the cases we use the life update. So it's the same. If you want to make something change, big change, always coming to the technician.
So this question. So
Yes.
what's the limitation of the Invisalign life update?
The limitation of the Invisalign at the beginning was the same. The same. So, for example, with mandibular advancement, it's not functional. You need to submit the case. And right now, for example, you can use more than 1 millimeter in Invisalign life update. So it's the same. What I would do the distalization by myself more than 1 millimeter. So maybe the life update, the sequence, it will be changed. So sometimes the limitation right now, I think is a very good limitation, because if we do by myself, okay, 2 millimeters, maybe I'm going to do something wrong. So it's better to the technician. So in Invisalign, right now in Invisalign, you move all the detail you want, and then the life update changes. But normally, I always the same. More than 1 millimeter or more than 2 millimeters, it's better writing to the technician. The technician will give me the support, because they change maybe the protocols or maybe the others.
And also, I get a feedback from Italian doctors. Is that go to Invisalign life update, for example, even move the teeth with 1 millimeters. So just well, maybe this teeth I move, but when I use life update, other teeth change. So they need to send the comment again. But for smart teeth, no
Yeah.
need other.
And the other problem with the life update with Invisalign is they change the protocol. For example, for an intrusion, in case that they have a deep overbite, I always ask a frog protocol. Do you know frog protocol? It's like in 4 aligners, intrusion only for incisors, so stopped incisors, 4 aligners canines, stopped canines, incisors, canines, so it's a frog. Well, when you are in Invisalign and you ask for the frog protocol, and you in the life update you change this protocol remove, and the intrusion start all again. With a Smarty, no. With a Smarty, the protocol.
How to comment it by in Smarty?
The frog protocol,
Yes.
asking, writing.
They know it.
You
I
know.
tried it. I tried this one. And then they knew the problem.
So you write, dear colleague, please apply the frog protocol from the intrusion. Yes, 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 yes.
Yeah, even yes, when we want to institute the anterior teeth, in the line, we first of all, we progress, and then we institute,
Yeah.
and then we check.
The P protocol, protrusion, intrusion, retrusion. This is the PI protocol. This protocol, if you write to the technician in Smarty, apply the PIR protocol, is like in class 2 division 2, it's typical, is protrusion,
Yeah.
instead it's open the space, is protrusion, intrusion, retrusion. Yeah, this is another protocol. The technician know about this, and the frog protocol too, and the molar first too. So all the protocols, all the normal protocols that you maybe invent one protocol, but the normal protocols, the technician knows all the protocols.
And how about the institute the possibilities? Like, I want to institute possibilities, so how can I comment? I need, I have to explain for them that, first of all, I want to institute first molar, and then fix first molar, then remove attachment from first molar and add second molar.
Yeah.
I have to explain like this.
Yes. Yes. If you want, so all that you want is like I say always, all that you can hear, all that you can explain is better. Here, in this, for example. So, the same, expansion, correction, in the crossbite. So, for example, in this case, what's the problem in this case? We have two problems. The problem of transversal problem, you can see, okay, and the sagittal problem. So, do you think if at the beginning I start to distalize in a crossbite, it will be correct? No. If you have a crossbite and you start expansion and distalization at the same time, you don't correct this. So, the first, what is the first most important plane? Transversal plane. So, in this case, the first, expansion and distalization. So, the first we need is to correct the transversal plane. When you have correct the crossbite, you start to distalization. So, you need to write. You need. And, for example, to take profit from the diastema on distal 33 to center the midline.
So what is the exact sequence you do the correct occlusional plane, and then you do the expansion, and then you the distalization, the last step?
Normally, so the first you can maybe you have problems in the three planes: transversal, sagittal, and vertical. The most important is transversal. So you have crossbite, for example, you have crossbite, class 2, and open bite, for example. The first you need to correct is transversal. The second one is sagittal, and the third one is vertical. So sometimes sagittal and vertical, maybe you can eat together, like mini screws or whatever. But the transversal is the most important. So you have crossbite, correct the crossbite first, and you start to make the distalization. If you do distalization and expansion at the same time, it doesn't work.
I've seen Nasmati in the breast with face mask therapy. So what about other extraordinary plans like headgear, especially for treating teenage cases with excessive maxillary vertical growth?
The headgear,
Yes.
you say? No, headgear no, the face mask, no with headgear. Headgear you need a bunch of the model. The headgear is not, for me I don't use headgear with clear lines. Because the distalization is it's good with aligners, is very easy. So normally the headgear, the traditional headgear, is to correct the class 2 with the protrusion of the maxilla.
What about the excessive maxillary vertical growth?
Yeah, you can, if you have a maxillary, you can do, you want to make the intrusion,
Yeah, for the whole upper arch.
the whole upper arch. But normally you need to use, or maybe with aligners, and maybe with mini screws. Yeah. So the headgear, normally the headgear, the traditional headgear, like in a patient with an open bite, normally you use the headgear is like the maybe over cervical or maybe here. So different from headgear. I think the last headgear that I used is 10 years ago. So with aligners I don't use because the indication from the headgear is for distalize. So the distalize with aligners is very easy. Very easy. In growth patients, in adult patients. So the fascial mask, yes, of course, you need a fascial mask. It's true that some doctors are using, for example, mini screws in the upper, between the first and second molar, and mini screws around maybe near from the canines, and they use elastic mini screw to mini screws, or maybe mini plugs. So you can use for no use the kid, for no use the facial mask. But normally use a mini screw in kids. For me, I use, but not a lot. The mini screw is more for adults. The headgear, but the headgear, the traditional headgear.
Maybe they got problem with our plan improvisation. So
You can think the same. For example, you have a patient that you have an open bite, and you want to close this open bite. And you think it's growing patient, and do you want to use the mini screws? You don't want to use. Okay, you can use the Smarty, and you know the Smarty have a solution. This is the posterior bite ramps. So you can put a posterior bite ramps for the patient is touching these ramps and making the intrusion of the molars. With this intrusion of the molars, the mandibular is counterclockwise and close the open bar. This, for example, is a very useful tool using posterior bigram.
If you want to put the egg on there or anything,
If you want to,
if you want to see
yes, yes, to comment or from the prescription. In the prescription, when you ask a new case, in the prescription, if you try to kinder or teen, directly you have the different solutions. Age 8, age 9, age 10, 11, age 16, all the solutions. So in the prescription, there you have to click on, in this case, age 11. So if you want transpalatal bar anterior or posterior, this is true, or nance button, you need to write. But you can't click on the age 11 solution.
in adult patient doesn't have that, so you can click on.
In adult patients, you don't have in the prescription, no, but you can to ask writing. The only is mandatory is the ST5 with the palatal. This is mandatory. When you ask S11, maybe in adults, it's possible, but it's important you have the scanner with the palatal. This is very important. But you can to ask, yes.
In smarting, do they have the budget? The budget?
Yes.
They have them?
Yes.
Yeah, I remember you can ask, but we didn't show you the system. But you can write in the prescription, special note, or in the comment. You say, I want the bigram. We will design for you.
Yeah.
Yeah.
The bigram, anterior bigram or posterior bigram? A bigram? Yeah, but bigram. Normally, for example, when you have a patient,
I think bigram they don't need because during treatment we do not so
No,
they move the teeth.
but for example, a bigram, for example, is you have a patient with an open bite, okay, and you use, for example, bigrams in the posterior area. So this movement in this intrusion of the posterior, so the mandibular is changing anterior counterclockwise. Okay? So this is a bite jam. So normally the technician is doing this bite jam. So you can do ask, or normally the technician no, because you ask, for example, I want intrusion of 2 millimeters of upper molars and 1 millimeter for lower molars. It's logical you have a bite jam. And this bite jam, normally you need to be careful because the bite jam normally in more cases is like here. It's not like here, it's like here. The mandibular is moving forward, it's counterclockwise. So for example, be careful in class 3. Class 3 malocclusion with bite jam, be careful. Because if you have a class 1 and you do the intrusion and you don't do the, in this case, the distalization of the lower, maybe the class 1, you change to class 3 for this bite jam. Be careful with this. More questions?
A scenario here, growing patient, adolescent patient, but the doctor wants to reserve a space for the erosion of the second molar. So the doctor wants to visualize the first molar, so it will somehow close with the canines. What's your take on the visualization without having an implant screw? Because you mentioned that the implant screw is not recommended for young patients, right? And for example, there's short clinical crown,
Yes.
right? So that's quite a difficult case. So how do we do about that?
This is a complicated case because you have a small ground and you want to do visualization.
Yeah. So
It's-
for
it's-
example, that case
Yeah.
cannot be treated.
Yeah,
with alignment.
it's complicated. It's complicated. So in these cases, if you want, this is a very good question. You have a patient with a small crown and you need to do visualization. You know, if you have the aligners works very good when you have a very big crown. You know, because the aligner with all bigger is better because it's more, you have more to move. Okay, when it's a small crown, it's more complicated. So in these cases, you can put the more bigger attachment that you want, that you maybe can use that, or maybe with power arm. Use a power arm with mini screw. If you cannot use a mini screw, you have complicated. This is very complicated.
Is it possible like to do refinement eventually, since you have, for example, get the team package and just do unlimited
Yes, of course, you have
refinements?
all the infinity refinements, so
Yeah.
this problem. What is, for example, if you don't, for example, this is more complicated case. Growing patients. With parents, they don't want to use mini screw for the child. With small growth. And well, the last is no cooperation. Yeah, well, there's no, but a good cooperation. So, with this another option, gingivectomy. You have gingivectomy, make this crown bigger for the aligner to have more. But this is problem. We need a.
So this is what we say, that it's really the management of the doctor. That's
Yeah.
very important.
It's the most important. It's the most important. So, you know, the doctor is the most important thing here. In this equation, the only equation important is the doctor. The difference is variable. For the doctor is most important. So you are the most important, and your diagnosis is the most important. So your treatment plan, but it's your diagnosis is your treatment plan. If you delegate this for the technician, so maybe the best technician in the world, but it's not you. You are the orthodontist. So please use your knowledge to always write all that you want. What happens in the smart teacher? If you don't write, it doesn't.
Ở đây có một cái mà em nghĩ là chúng ta có thể test thử, tại vì khi mình lốt bằng tiếng Anh ấy, đôi khi mình bất công như mình mà để lốt giải chi tiết lại bằng tiếng Anh thì ra cũng mất thời gian ấy. Thì bây giờ cái con AI hồi xưa của bên hãng Smarty nó dịch tiếng Việt thì nó chưa ổn, mà càng ngày mình thấy nó dịch tiếng Việt là chính xác hơn. Thành thử ra các bác sĩ khi mà mình lốt lại ấy, mình cứ mô tả chi tiết bằng tiếng Việt thì nó sẽ đỡ cực hơn là mình phải lốt bằng tiếng Anh. Chỉ có một cái thì các bác cứ thử xem, tại vì là cái này là Hiếu thử thì Hiếu thấy là càng ngày nó dịch nó càng chính xác hơn. Thì giống như ở đây là bác sĩ lại cũng lốt lại bằng tiếng Tây Ban Nha này. Thì mình lốt bằng tiếng Việt ấy, thì nó sẽ đúng ý của mình hơn. Tại vì nhiều khi mình lốt bằng tiếng Anh nó hay bị sót ý lắm. Thì mình cứ test thử đấy xem. Thì Hiếu thử thì Hiếu thấy là nó đã cải thiện rất là nhiều so với trước đây. Thay vì mình lốt bằng tiếng Anh mất thời gian.
So many questions?
And how about impacted case? How you control the impacted?
Lymphatic teeth?
Yes.
Yes. Normally it's the same. For example, many they have this case. For example, they show you one case. And so you can see. In this case, for example. This case. This case we have deep overbite, compression, and we have you can see here the impacted canal. You see? Okay. So, in this case, normally you know, in a Smarty, the purple teeth is the serious teeth. Okay? It's really different. So, in this case, for example, let's start with distalization. In this case, so I use elastic, class 2 elastics in the right side. So here, I start to open the space and maintain this teeth, and I always, maybe here, I have in data, I have the bottom or the teeth width. Which is the 13, the width, 8.25. So, which is the 63, 7.10. So I need maybe 1 millimeter round in the other. So exactly 1.2, because this one plus 1.2 is 8.3, similar like this. So in this case, I open
Ý làm trên
the
chỉ cách
space
ta làm lại thôi đúng không?
for and
Để
when I
mình
do
trả lời
it,
cho.
I don't have the finding of this space. Give me 1 second. No, I don't have any finding yet because it's still in progress. So in this case, the patient here is using a mini screw here, a mini screw with a TMI arch with impacted teeth. So I start align the teeth, correcting the class 2 in both sides, more to the right side, and we end with the mini screw. I use to upload the straight the impacted canal and open the space. When this canal really is outside, at least 50% of the ground, new scanner, or maybe I change here, maybe I change for that normally I use like braces for lower incisor here. I use, for example, I use here a 2 SMARTY button and elastic for the canal, for example. And when the teeth, because normally these patients are women, a young woman, they don't like to be with the space here. So sometimes I maintain this teeth all that I can. So when I have the permanent canal near from the deciduous, I extract this and new refinement to move. And normally it's using mini screws and the lines. So I don't need to wait to this impacted teeth is outside. I can just start here and to move and correct. For example, you can see here. You can see the protocol, the front protocol.
You finish this step?
No, it's already, because I start this case on, I approved on July. So it's 16 one alignment. So right now it's finishing alignment 45, maybe 45, 50. So you see the front protocol for intrusion, the class 2, in this case in the right side for distalization. You can see here the bite runs, the anterior bite runs. You see? The anterior bite runs. So I start here,
Cái này
the anterior bite
cái
runs.
toàn cảnh là biết
And
mà.
when I finish the case, hard contact.
Nếu có thì ở Anh còn có nhiều bệnh nhân có phim.
When you have a case with overbite, you need hard contact. In red. Always in red. In posterior. It's very
Có gì
important.
có gửi anh.
Or you make the, or we can make the open line, I mean overcorrected until this.
Sorry?
Or we can make the overcorrect
Yes.
in until this.
Yes.
Open line.
Yes. Normally open bite of maybe 1 millimeters of overbite. But normally, as you can see here, this is the initial, and when we finish, it's like 1 millimeter of overbite and overcorrection in the posterior area in hard
Cái này thì tốt.
And in open bite, it's the opposite. In open bite, we maybe 3-4 millimeters of overbite, and in the posterior area, soft contact, maybe green. Green. More questions.
How about impacted second molar? I mean
Impacted on second molars
yes.
with mini screws. You need to extract the third molar and use mini screws. The impact of the second molar is complicated. It's complicated.
Without mini screw, is this possible?
Without mini screws, maybe from the position. If it's impacted inside the bone, you need mini screw. If it's outside, yes. If it's outside, you can do ask by yourself, like this one. Imagine that you have this molar is like here.
Yes.
So maybe you can use this cut. Maybe here, if you can ask, or maybe by yourself, using a cut. If not, do by yourself on clinic. So here you put a tube, here a tube, and with normally with knitting, with knitting, a wire and a coil, or maybe using a square 16 by 16, using like this here, full upright.
Em có biết hôm nay em gái là Jose nói với anh không? Extend because in the first time this morning he told me that you can extend the margin liner.
You sorry?
I mean you can extend the in
So
margin.
you find
Yeah.
yourself.
Yeah.
But in this case is when you lost the anterior teeth. So in this case you lost this teeth, okay?
No. I mean I extend after the behind the second molar.
Yeah.
I extend the margin.
It's in the margin.
Yes.
Yeah, but this is in growing patients.
No, what she mean is, can she customize it a little bit, like she extend the margin in this case, and then she do the
I put the button.
button.
Yeah.
Yeah.
Yeah, on the extend part,
Yeah.
and I put two attachment.
Yes.
Yeah, and I put one button in that second button motor,
Yeah.
and set the place and use elastic to
To upright.
upright.
Yeah. Yeah. So its case is different. So normally, the when you want to upright the molars, if it's impacting molar, if it's inside the bone, minuscule. It's minuscule. It's impossible because inside no gingirectomy, no osteotomy. It's minuscule. If you have like maybe like 30-40 degrees, maybe with making a cup and using tubes or braces or that you feel comfortable. It's like the braces. So this is the good thing that you have the anchorage for the liner. And sometimes you cut the liner here because you need this molar free. So you can to cut the liner here and you use here a tube and a tube. And you have the anchorage for the aligner and here to upgrade, to upright. So maybe every case is different. So it's in, I would say the same. If you have this case with braces, how do you treat, for example, with braces? The same case that you say.
This room, so
With?
this
Or the same, with the liners?
But the thing that I want to control this minuscule.
Yeah?
Because sometimes the zinc zero will cover the minuscule. So the patient cannot wear the elastic and I cannot change the spring also.
Yeah, but this is happening. This is
And a strong wire-
there are things that you can control and do not can control. So if the mini screw is covered by the gum or whatever, you not can control. Or maybe you need to gingirectomy. So it's the same. Sometimes they use a mini screw from the open to close the open bite. I use a mini screw. So maybe one or two mini screws, they maybe is broken. Broken is not normal, but happens. What happens is broken. You have the mini screw inside, you put another mini screw in another side. It doesn't matter, no, it's different. So, but a mini screw, maybe they will remove with the for use of elastic. Okay, just use another mini screw. This is it's like a patient with braces. What happens? The patient is coming every appointment with a lost braces. So you put another braces. Yes, it's the same. You have always have. I think it's different from the emergency, from things that will be happening, but it's possibility. Yeah. But what do you think in fixed appliance in braces? If you do in these cases with mini screw, with smart is the same. Use the mini screw. They don't change.
In the previous so after the extension, then you use the manual out
Yes? What does it mean? Is this. In this case, we do the distalization, but the principle is the same. Here, normally the extension, this is the arc, okay? But you can see the final position. You can see the movement. In this case, because I'm doing distalization, but the movement is the first molar is distalized at the same time. Movement mesial out, distal in, and if it's possible, lingual root torque etc. at the same time. This is to change the form of the arch. You can see here, or for example, you can see in this. Distal in, mesial out. So, this is for not all the cases, but normally, for the ideal cases, for the most predictable expansion, is always expansion. Normally, most of the premolar area with the movement of distal in second molars, mesial out in first molars to change the arch. More questions?
When I practice work, I feel that the material of Smarty is harder than Invisalign, so is there any tension when we use this one?
So,
Yeah. So, because this one is harder, I
Yes.
feel the material is harder, so is there any difference when the patient uses Smarty?
no.
Very
No. So this is the doctor asking is different between the material from Invisalign and Smarty. So this is a question a lot of doctors always say, because when you use you feel the material of the Smarty, you feel this like more hard, like Invisalign. So this is normally for me, it's better. Why? Because a soft material, we think soft material move better the teeth, or maybe it's less pain. This is not true. The material important is the adaptation of the material. So sometimes we give a lot of information, a lot of the material is the most important. The material is important. It's very important to have a good material. In fact, Smarty has his own material, patented material. Is little hard on Invisalign? Yes, it's little hard. But this is not bad thing. This is sometimes it's bad, sometimes it's good. For example, like in this case. In this case, with this appliance is amazing for the extension. But if you use this appliance with the attachment and it's very hard, normally for the patient to take out is complicated. Yeah. But this complication to take out, normally the patient you need time to strike with the teeth, maybe with the nail, where it's complicated. Yeah, but it's better because the expansion, the control of the expansion is better than in Invisalign. The control of the torque is better. So it's true that you have more retention, but it's not pain, no pain. It's not uncomfortable. It's the same. For the retention, of course, is better in the good and bad terms, but it's better the retention. So in which cases you use the palatal, the transpalatal valve, and the aligner, maybe for the patient it's complicated to take out. So, however, the patient at the final very well. So the material doesn't matter. Always you use a good material. It's different. Surya Smile, for example, Surya Smile use the same material that the X's, not the retainer. So by patients that we treat with Surya Smile, they have a lot of pain, because they need to change every 2 or 3 weeks, because the material is very hard. It's the same material from the retainers, from the A6 retainers, the same. So you need to think about extrusion in one teeth with this material, the patient have a lot of pain. But this is not a special material for move teeth. They use the same material. Okay, I have this material, this good material, I use for move teeth. No, this material is for not move the teeth, for retain the teeth in the position. So it's different. So at the end, the material, yes, it's important, have a good material. But it's more hard, more soft. Maybe in some cases it's better soft, in more cases it's better hard. So it's different. But normally, for the day by day, for the patient, my patient who I treated with Invisalign, I treated with a Smarty. No one patient tell me, in fact, I have this patient, for example, I want to show you one case. Yes, I show you. Yes. This patient. Okay. This patient was treated with Invisalign. I finished this case. This case started less 1 year ago. Open bite, maybe for tongue cavity with retainer. This patient used Invisalign before. Come into my office. No with me, another doctor. Come with me. Vicente, I feel that I cannot to bite because maybe for the tongue cavity, maybe I don't know if it is the final result because he treated like 6 or 7 years ago, but the problem from is they can bite. So we start with the Smarty. This is the first. This is refinement in November, and this is in June. Okay? In 1 year. This patient were Invisalign and Smarty. What do you think when we feel more pain? With the Smarty or with Invisalign? With the Smarty is less pain. In fact, at the beginning, they tell me, Vicente, it doesn't work because I don't feel pain. Because Invisalign, every change, I feel pain. So the patients normally associate pain with effectiveness. No, it's not. No, normally it's not. Or tell me, Vicente, I need to change because this is a light package. I need to change every 10 days because I don't feel nothing. I can do change every week or every 5 days. No. You need to change every 10 days. So using at the beginning, Invisalign. Now Smarty. The patients they tell me, this is a layer small here because this patient likes a lot of coffee. So with Invisalign, this is normally at 3 or 4 days, it's very dirty with Invisalign. With the Smarty, drink a lot of coffee, it's like in the first day. So this is one of my first cases that I finished with Smarty, and the other case is this one. And for example, this case is, I think, is the second or the third case that I don't ask for refinement. It's true, it's not a complicated case. It's class 1 malocclusion, chromium. So this is in October, and this is in June. No refinement. No refinement.
After how many months?
Between it's June in October in 8 months.
Is he have a problem snoring?
Sorry?
I mean, he has a problem snoring?
Huh?
Snoring.
No snoring. Because with this kind of patient, I used to recommend them you the MA. Yeah. For the profile maybe, but you know, normally the problem with the patients with the patients with the black patients is they have the big protrusion. So normally they have maybe this class 2, like we said before, no? The pathological class 2. No? They have the profile from class 2, class 1, dental class 1 is medical class 2. So this is maybe one of the first case, the second or third case that I finished only with the first package of aligners in 8 months. So, and this case, see, this is with Invisalign before. So at the end, sometimes it's like the limitations we ourselves do, no? Okay, it's hard, it's more pain, no? Or maybe it's hard, very uncomfortable. It's not true.
No? And the movement is the same. For example, in the distalizations, it's my clinical opinion. Distalization is better with Smarty. The distalization is better. I have less relapse with Smarty than with the Invisalign. Maybe for the material, maybe the material. So it's like hard. The movement is better. In the relapse, is less. The material soft. Maybe you distalize, but how it's soft, normally the movement to coming back to the base. So it's my clinical experience. No, it's not an article, so it's clinical experience. Well, and you tell me this one, this article. I don't know if you have this. Okay. There are a lot of articles, for example, this article, for example, this study is the effect of this is not the actual material, this is the previous material from Smarty. There are some material that is better than this. So the article is this TBG modified with TQ using artificial saliva because activate with 37 degrees with the oral normal temperature. So you have this article, if you want I can share with you. Okay, this article, you have all here and the results. We have another article like this one, this one. Okay, 8 years. So this is another article. This, for example, we compare the color stabilities of the three kinds of orthodontics. So different material. What is the best material for the color? This one. So, if you have, what do you want to know about the different articles or maybe the science behind the Smarty, you can ask, for example, to Daniel or maybe for Smarty. We have a lot of articles behind this. So it's not this science behind it. It's not only that we see, no, we have the best aligner. Maybe it's the best aligner from some cases. Maybe Invisalign is a very good aligner. So I never say it's a good aligner, but the Spark or Ethel is a good aligner, Smart is a good aligner. So every aligner, the big brand aligners, of the materials, of the software, maybe have different options. So you need to feel comfortable with the system. So try to make cases, not 1 or 2 cases, because this is not enough. You use maybe 15, 20, 30 cases, and you try. You don't like it, okay, use it. You don't like it, okay, stay with the brand that you feel comfortable. This is not like a soccer team, no? I am from Valencia team, no? It's my team of all my life. I don't change, no, sorry. This is that you need to be more comfortable and to be the best for your patient. So for me, right now, it's a Smart team. It's like this. I tried the other brands. So for me, for the technician, for the material, for the software, it's the best. And the other is they always, Smart is always new update. So now it's very, very growing and changing. And in fact, for me, it's very important. The most important is have a very good software. We have a very good material, very good software, so the doctor can to sit in front of the computer and in 15 minutes approve a case. This is the idea to have a Smart team. So make easy the work for those who don't. 15 minutes, you can approve the case. This is the idea. More questions?
How about the material of the retainer and the tape
The material of the retainer is different.
is
No, it's different. Because, for example, the material for the aligners in a Smarty is like a slug, it's like a TPG with TPU, and the retainer is more TPG. It's more hard because you need not to move the teeth. So it's different. Yeah, retainer, yes. Retainer is harder, yes. Because in one you can do one to move the teeth, and the other you don't want to move.
Yeah.
So it's different.
I have a clinical question about overcorrection. You
Yeah.
mentioned about overcorrection. Some doctors would really require or request for overcorrection. In your experience, when do you recommend overcorrection? Do you recommend it in all cases?
No, for example, the overcorrection, you have two kinds of overcorrection. Maybe two in the same smart check, like this. For example, here I do an overcorrection in the treatment plan. So you can see I have hand posterior contact and only 1 millimeter of overbite. This is an overcorrection in the treatment plan. But for example, I think maybe it will be not happen. I can ask to the technician an overcorrection aligners. So we can do more overcorrection. And I ask to the technician, okay, at the final, you can see this is 4 passive aligners, the 4 passive final aligners. So I ask to the technician, before or when you finish the passive aligners, after the patient, please give me 3, 4, 5 aligners for overcorrection, in this case, with extrusion of the posterior area, or maybe the intrusion or the anterior area. This is different overcorrection. I always recommend in cases with overbite, increased overbite, the overcorrection during the treatment. So during the treatment is, you have finished, hard posterior contact, 1 millimeter of overbite. But if you don't make you think it will be not happen that you want, please ask overcorrection, but overcorrection, final overcorrection. For example, the C-chain, you ask me the C-chain, no? For example, to close the space. So, imagine in this case, I have the DPR. Okay, so I have my final passive aligners. So, maybe a little space still here. So ask to the technician overcorrection for C-chain in the lower arch. So when I arrive to the aligner number 57, this is my active aligner in both arches. But for example, in the lower arch, I have spaces, but not in the upper arch. To the patient, I open the back of the aligners and I give to the patient. In the upper arch, 58 is passive aligner. In the lower arch, aligner 62 is overcorrection C-chain. So you can use this. You understand? No. Yes? You understand? No. No. Okay, I repeat. For example, imagine this case. So, the treatment plan is correct perfectly. Well, at the end, imagine, at the end, in this, my last active aligners is 57, right? Because these aligners, these aligners are passive aligners. Okay? So, in this 67, when I see my patient, in the upper arch, I look at here, the upper arch is perfect. But in the lower arch, maybe I do more IPR and I have a little space here. If I ask the technician before the treatment plan, here to add an overcorrection of C-chain, because maybe I think I do more IPR that I need here, and I have a space, so I can use 58 aligner in the upper arch and use my first aligner of C-chain. So it's true that I need to ask before the treatment plan to approve. So it's important. Well, so for instance, it's important maybe in some cases. So ask passive aligners, or maybe ask C-chains, or maybe overcorrection. If the overcorrection is the same, if I ask overcorrection for example, the extrusion of the upper and lower molars, maybe I use in the upper maybe passive aligners, in the lower active aligners, or overcorrection aligners. So we can use all the things. So it's important at the beginning of the treatment plan to have all of these, because if I don't ask, you have space and I approve like In this case, I have a space, of course, I cannot close, maybe with a pressure, maybe with something, but normally I ask a refiner to close. More questions?
So normally after we set up a liner, so do you usually rescan the teeth to make the retainer, or you just order the retainer depending on the first treatment plan?
No, always a scan. Yes. For the refinement, the retainer, new scan. Always. Because normally my patient, I always use a fixed retainer. So with a fixed retainer, I like to the fixed retainer, the big one. I want to retainer the removable, the retainer removable is cover this fixed. So in for example in this case, you can see in this case, you can see is fixed retainer in the lower, fixed retainer in the upper. In this case, for example, is only in the lower, not in the upper. Why? Because for the occlusion, for the size of the teeth, if I put the upper retainer, maybe have a contact, and the patient cannot close. So normally, if I can, I use fixed retainer in the lower, fixed retainer in the upper, and removable retainer in the upper and in the lower. Double retainer. So I don't want to move. Okay. More questions?
So you use both the fixed retainer and then the removable retainer.
Yeah. Yes. Yes. Because I don't know if here in Vietnam, but in Spain, the patient have any problem with the retainer, or maybe I have a colleague, they don't use fixed retainer, only use removable retainer. So the problem is that the patient is not compliant with the retainer, you have a very big problem. Because it comes to the doctor, I have this big rotation 2 degrees, and I have perfectly 1 month ago. So you have a problem. So I prefer to use double retainer. But it's my protocol. So it's different, each doctor has different. Maybe doctors, they don't like the fixed retainer because the patient from the, maybe from the flash, or you can use, or maybe for the hygiene or wherever. No? This doctor has his own protocol. For me, fixed and removable.
The patients were the retainer online.
The all time. The first month, all time. The first month, all time. 24, like the liners, 22 hours. The first month. The second month until the 12th month, to the first year, 12 hours per day. 12 hours is at home at night, normally. And when we finish the first year of retention, normally it's using maybe 3 times per week, like Monday, Wednesday, Friday, for example, using around 12 hours.
I still wonder about how to rotate out of the regulation, because you told me that you 8 years ago, right? So for the past time you did 8 years ago. So I just wonder how can we rotate the power plan, because it just be aligned as it do it. We just like insert the this, no?
Normally, instead the aligners, one of the things they do is to plane the occlusal. Why? But for example, normally for the bowing effect of the liners, when you're doing the intrusion of the anterior, which is the other effect, the extrusion of the posterior. So if you want to, you have an inclination of the palatal, maybe you have a very open bite, normally you need a mini screws. So this is mandatory for these cases. But if you have an increased curiosity, normally if you are doing with a good protocol intrusion of the anterior teeth incisor and canine, normally the extrusion of the posterior is like movement that is very good, intrusion, extrusion. This is to maybe to the QRSP and normally to the palatal plane. Normally, that is true. Every case is different. Every case. For example, I have patients, growing patients with knee screws, a very big open bag with knee screws. In fact, I can say you a very complicated case. For example, that I treated. I say to the parents, this is a surgical case. It's a surgical case. It's a surgical case. So the patient is 15 years. In Spain, normally the orthodontic surgery in the social security is included, but it's 20 until the patient has 20 or 21 years. In men's, normally 21, 22 years. So we can do with this patient. Waiting for the surgery, and the patient, for example, have very careful to, for example, this is
Cái câu hỏi của anh đã chia sẻ với mọi người, cái câu đấy nên hay lắm mà.
Dạ, cái câu đó nghĩa là từ vì như thầy nói là thầy không sử dụng cái kia cách đây 8 năm rồi, thì thầy hoàn toàn không sử dụng, thầy chuyển điều trị cho những ca thậm chí ca tim và ca đang phát triển và sử dụng cây trong hết. Thì hồi nãy em có hỏi ở cái lần trước rồi thì thầy mới trả lời là như vậy thì đối với những ca ví dụ open bite có cánh mở vậy đi thì có thể là mình sử dụng aligner để làm đúng những răng sau, khi đó mình đóng khớp cánh ở răng trước. Nhưng mà em lại hỏi tiếp em, tại vì em mong muốn là có thể là xoay được cái mặt phẳng khẩu cái đối với những bệnh nhân đang tăng trưởng á, mà nếu mà cái mặt phẳng khẩu cái nó quá là mở đi thì bây giờ mình cũng có thể xoay được đối với bệnh nhân tăng trưởng. Thì bây giờ mình sử dụng hết kia nó vẫn là một công cụ nó hiệu quả để có thể xoay mặt phẳng khẩu cái để sau này bệnh nhân không bị cánh thở. Thì từ điều trị cánh thở cái vấn đề tái phát nó rất là nhiều, nên em sẽ ưu tiên là để điều trị trong lúc bệnh nhân đang tăng trưởng thì nó được bớt phần nào sau này bệnh nhân tái phát. Thì cho dù điều trị tăng đi sau này bệnh nhân cũng có thể tái phát open bite.
Thầy ý thầy là thầy xoay mặt phẳng khớp cánh, còn em là
Đúng rồi.
mặt phẳng khẩu
Em là
cái.
mặt phẳng khẩu cái luôn, em muốn xoay mặt phẳng trên mặt phẳng khẩu cái luôn. Thì đúng rồi, thầy xoay mặt phẳng nhanh rồi em là tại vì mặt phẳng nhanh nó vẫn liên quan đến răng, thì răng thì sau này đó nó vẫn là sẽ ổn thôi, thì nó vẫn sẽ có khả năng tái phát open bite sau này.
Thì cái này chắc là điều trị về cơ chức năng có bị để lỗi lên không?
For example, this case. This is a present. Very complicated. This is surgical. You know, right? Yes. But it's 15 years old. So, what happened with this case, for example, with traditional braces, normally is maybe extractions of the first premolars. You can see with the canine, the position of the canine. Here we don't have space for the first premolar. You can see the ideal is extraction. So if I do the extractions, maybe it's a limitation for the future for the surgery. So in this case, I will talk to the parents. Okay, at the future, this case before orthodontic surgery. Sure. But okay, let's go to do something to improve this child. Why? Because this child is only biting with here. It's only biting. This patient, they always say, Dr. Vicente, please, the only that I want is to eat. I only to eat. So, in this case, you can see that, in fact, I write in English, in this case. So, please do not move the upper arch and do not fabricate the aligners for the upper arch. Why? Because normally I'm waiting for the extraction of the third molars. So the upper arch, I lose one. Improve the alignment of the aluminum in the fossil deforming the lower arch. So you can see here is only the aligners is in the lower. So to open the space for the premolar stabilization, open the space. So here is this, I think is the first refinement. Yes, this is the first experiment. Before, now I have the patient with mini screws. I use a mini screw. So the mini screws, in this case, give me two different options. The first one, if I intrusion is smaller, this mandibular is counterclausal. So for me, it's better, or this big class 2. So the over is the patient start to have more posterior contact. So it's better for the occlusion, and at the end is the patient who wants to eat better. So this is. And this is the bite jump. We have open bite, yes, of course, we have open bite. We still have open bite, this is a cervical case. So we at least we have to improve this patient. Maybe in some cases, we have better results in the real life, so in the vision, no, in the smarty check. So in these cases, I need to give the patient something to resolve this problem. So this is a surgical case. The patient knows. In fact, with this case, it's a team. So when we finish, maybe with this case, it goes to surgical, and after the surgical, if I can, to prepare all the arch, the upper and lower, and give all to prepare and make the retainers, so for 21 years, make the orthodontic surgery with no another orthodontics. Maybe, I don't know. So, more questions?
In that case, why don't you keep intrusion the molar so that you can cover
Where?
in this case?
Intrusion the molars? Here?
The question is why don't you continue to intrude the molar so further you improve the open bite?
That's still the leader.
Sorry, I was when don't you intrude the molar?
Yes.
So that should resolve.
We solve a little bit more.
Yeah, but this, because this is not real. I got to the intrusion here 8 millimeters, but it's not real. You need to know what is the limit of the bone of the limit. Intrusion 3.41 millimeters, I think is enough. Maybe until 4 millimeters intrusion, maybe more than 4 millimeters is not good for the roots. Maybe you create that root resorption. So this is a real intrusion. I asked for example intrusion of 6 millimeters, yes of course, for us, but it's not real. You need to be, for this it's very important that the doctor know which the limit. It's like the distalization. We can ask a distalization of 7 millimeters. Yes, we can to ask 7 millimeters, but it's not real. Instead, with mini screws, it's complicated. 7 millimeters is not impossible, maybe, but it's very difficult. It's very difficult, but it's the same. And you know, the intrusion is one of the movements is very complicated for the roots. So normally have a resorption. So be careful with intrusion.
In that case, you only use the upper molar. Why don't you use the lower molar?
No, the lower molars, you have intrusion, true. But what happened? When you don't have normally intrusion around 0.5 or at maximum 1 millimeters, maybe it's predictable without mini screws. But more than 1 millimeters is not predictable without mini screws. So, in the lower arch, the mini screw for the intrusion is complicated because you only use mini screws in the buccal, not in lingual. So, normally when I use mini screws, I always say to the technician, intrude the upper molar, but the lower molar intrude, but maximum between 0.5, 0.8 millimeters, no more.
The patient has a big mouth or some bad habit.
Sorry?
I mean, the patient he had a
No, I think the person have some syndrome or whatever. It's not problem from the jaw. I think it's maybe any syndrome or whatever because you talk to the patient, and the patient is not maybe not normal. So maybe it's some syndrome. So, I think Daniel, maybe
Yeah.
3:30,
Yeah.
we finish?
You have
So,
any
after
other thing?
300 case,
Sorry?
I mean, you just more than 300 case, everything is good. So,
Everything
what,
is good.
what is the most problem you have to face
The most problem
with Martin?
with Smarty, like the other branch, the visualization. The visualization is complicated, but not with a Smarty, it's with clear aligners. So I talked before with a colleague speaking the visualization more than 2 millimeters, 3 millimeters. Is with only the aligner, it's complicated. But sometimes you need maybe a power arm and mini screw. More than 3 millimeters is complicated, but with a Smarty, with the other brands. The typical problems that we have with a Smarty is the typical problem that we have with other brands. I always say the problem is not associated with the brand, it's associated with the protocol and the movement. So if I, for example, I ask a visualization of 4 millimeters, really it will not happen.
You fix the Smartphone yourself or you have a system?
I approve by myself every Smarty check, every.
So you do yourself?
Yes, everything. I have very doctors in my team. I have like 4 or 5 doctors working with me, and sometimes I train my doctors how to ask to the technician, how to the diagnosis or whatever. But every case is approved by me. Every case I review every case. I approve every case. It's a lot of work. I know it's a lot of work. What is the reason what I work with the Smarty? We have the best software because I know my wife is here. I know who is to spend a lot of time the computers in weekend too.
More than
In weekend too. So I know who is spend a lot of time in the computer. So it's one of the reasons I want with the Smarty the best software, and if we don't have the best software, we're near to have the best software because I want the doctor in front of the computer said, okay, in 15 minutes can approve because this is quality life. I always say the same. When I was with the braces, I have best quality life with braces because I would do my diagnosis, I would my treatment plan, and every appointment come the patient to my office. Okay, I'm going to change the braces. Okay, and I'm going to change the arch. Okay, I'm going to. So it's in every appointment. Okay, now use elastic. No, take out the elastics. No, leave to change. Okay, but with this, you need to have very in your mind what is your treatment plan, what is your goals, and how to achieve these goals. Because this treatment plan, maybe it will be happens. So then you need a lot of time to make the treatment plan. So if you have the tools, you have the very good technician, you have very good material, you have the different solution to achieve these goals, you see you have the best system. And this is like Smarty is for me right now. No, you're welcome.
assistant.
So, any question? Yes? No?
One last question, maybe.
Sorry?
Yeah, one last question.
Yes.
For example, in patient with the narrow airway, another time if we close the open bar. For example, if the child has some habit open bar but already have a narrow airway, at the time it can be risky if we close the open bar. And at the time, if we have to close the space, I mean like close the open bar, and if we have no chance to avoid or it is inevitable to avoid the everybody from towns and because the patient might have some like referential problems and like that.
Yeah. You see with the narrow airway. Yeah. Normally normally the open bite is associated with a narrow airway because the mandibular position is more back. So we have very straight. So in these cases, when you correct the mandibular position, maybe you have an open bite and you're treating the posterior area with the upper molars. Normally, this mandibular is going counterclockwise. So this movement, so forward, is maybe they did the airway. So this is one of the solutions. Maybe with the mandibular advancement, for example, the ACE8 solution, this is another solution. So we have different solutions. Or maybe you say these patients have habits. So if it's a younger patient, you can use, for example, the Joy appliance. The Joy is, for example, I have one patient with 5 years old only using the Joy appliance. With like this case, the other case.
Is it okay? Sorry, is it okay for the adult patient? Because, for example, most of people they're not very aware for the orthodontic. So mostly now during these days they become aware. So it's kind of late for some like treatment as an adolescent or something like that because they've been grown already. So at the time, how we manage? Because I find some paper like it can be a problem if you close the open bite as a normal class of migration. And also if a patient has a sleep apnea, at the time it can be the tongue blockage at the airway. So is that okay?
Yeah, maybe these cases you need to have a consultation with the specialist of the apnea, for example. So normally one of the things, one of the best package from the patient who have apnea for the retroposition of the mandibular is the GS. The GS to advanced mandibular in adults. This is one of the options. Another option is not still in Europe, it's in China, is the solution, the S19. S19. So it's the for apnea. So normally, for example, every patient is different. So if you have a patient with apnea for retroposition of the mandibular, you can do a GS with mandibular advancement for adults. This is the best. This is the best package. So if this is not a real position because it's a functional, it's like typical the patient who sleep like here and the mandibular is going down, maybe you need to speak with the or maybe this apnea because the patient is like far. So maybe each patient is different.
Because my colleague is like also offered, she just tried to contradict about my opinion. That's why I just want to make sure. Because she told me like it's better not to trust it, but I would say many other possible solutions to fix problems. So,
They to say it's not good to close an open bite. It's like to say this is not good to substitute a lost teeth. No, it doesn't matter. So I do have an open bite, you need to close the open bite.
Yeah.
Because the problem for the open bite is not only, for example, is you cannot bite well, you cannot eat well, you have the open bite. Normally, these patients these are dolichofascial patients, so maybe have mouth breath. So this is more problems than only the open bite. So you have an open bite, you need to close the open bite. Maybe, perhaps they have an habit and tongue habit. So this is true. I always speak with the patient, the adult patient, and say, okay, I'm going to do orthodontic treatment. I'm going to close this open bite. But you have a tongue habit, you need to go to a specialist of the oral modification. Yes, because if you didn't change this habit, okay, it's like this patient, I said you before, they start with the Invisalign, I agree with this Martin, I will say you need to go to the functional because if you don't reduce this habit, this problem is happening again. So it's important. You're welcome.
And also how you use the Zoy appliance.
Sorry?
I mean the Zoy appliance.
Yes.
How do you use?
Normally.
Maybe the side of the hole really small.
No,
All one side.
No. This 4 or 5. I think it's 4 or 5. Four sides. It's like XS, S, M, L. It's 4 different sides. So it's different from the size of the mold. So this
Side of the hole and the side of the mouth.
no, the side of the mold. Of course, because you need to use. So for example, the XS is for patients between 3 until 5 years, 5 or 6. The N is between 6 until 8. The L is 9 until 12. The M, between 12 until 16, maybe around this. So the important is the size. So you need normally when you ask a joy, in this case, Smarty know which is the width of the arch. So they send you, okay, I want a joy, and they send you the joy exactly for this month.
But you have to change the way of breathing, change from the mouth to the nose. So we have
Check, of course, you can check. So for example, I use the joy. In patient, we have breathing mouth breathing. For example, this is very special. All patients they have the finger habit. This is very for to sleep. So in these cases, it's very useful. So, yes.
I would like to ask you how do you apply aligner for the deviation patient?
Aligner with investigation. With the ACE 9, ACE 10 solution. Yes, because this 10 solution is a posterior occlusal spleen. So this posterior occlusal spleen normally will not have changes deviation. Normally you have a crossbite. Posterior crossbite, normally. Because this posterior crossbite is scarred, like maybe in primary lesion or early mixing lesion. This makes a lateral desviation. At the beginning it's functional. Maybe if you don't correct this functional desviation, maybe it finishes in a skeletal desviation. So the best appliance in this case, the best solution is the S10 solution because it's posterior occlusal spleen. The patient is using.